welcome to another episode of the ResearchWorks podcast.
Oh, hello.
Hello. I'm a bit thrown because normally Dana does the introduction and today I'm doing the introduction.
Thought I'd just mix it up. What's good? I like it.
It's that time of the week again, and we're so excited to have you all listening in today. And we're also excited because we have an in-studio guest with us.
Yes, love it.
Exciting topic to discuss, and Dr. Asha Bowen is in the studio to do that with us today. Welcome, Asha.
Thanks so much for having me. It's fun.
So nice to have you in the studio. We were just reflecting. We thought we'd share the last time we spoke with you. We were all in lockdown. It was in the midst of COVID. I was in some room somewhere. You were at home
I was at home under a doona to try and soundproof my house from my family. And Asha, I don't know if you remember where.
I think I was probably in the hospital in a small, tiny little room trying to stay away from everyone else.
Yes. What a time.
Very much so. So it's nice that we can actually speak about and talk about something else. And today we'll be talking about RSV, a very important topic because of its impact it has on so many young children.
Absolutely. Yeah. And I think we all, whether we're aware of it or not, probably have a story about RSV or a connection to someone who's had RSV. So I think it's very topical and very relevant to all of our listeners.
Yep.
But before we get into it, let's tell everyone a little bit about Asha. So, Associate Professor Asha Bowen is most certainly an expert in the field that we're going to be covering today. She's a clinician researcher at Perth Children's Hospital and Telethon Kids Institute. Asha's the head of Department of Infectious Diseases at Perth Children's Hospital and the program head of the End RHD program at Telethon Kids Institute. This uniquely positions her for rapid translation of research results with impact globally. In 2020, Asha became involved in the COVID-19 research and is the chair of the Australasian COVID-19 Trial Global Steering Committee. Asha has received prestigious recognition for her research and numerous awards over the past few years. Some include the Australian Society of Infectious Diseases Frank Fenner Award, which was in 2022, as well as the Eureka Prize for Emerging Leader in Science. Asha is also the chair of the Australian and New Zealand Paediatric Infectious Diseases Committee, Deputy Chair of the Australasian Society of Infectious Diseases Clinical Research Network, and Vice President of World Society for Paediatric Infectious Diseases.
Oh my gosh. I had to wait. That is very, very impressive. And I think not only is it impressive of reading such a comprehensive bio, but the fact that obviously we're speaking to someone who's really well knowledged in this area as a clinician and as a researcher. So yeah, I hope everyone's ready for this episode. And I think the sort of topic we want to talk about is RSV, but there is an article in particular that we want to center our conversation around. There's been so many exciting developments lately, and the article that we're going to be discussing is titled Bivalent Prefusion F Vaccine in Pregnancy to Prevent RSV Illness in Infants, which was published in the New England Journal of Medicine in April 2023. So the author list is really quite incredible, led by Professor Beate Kampmann from the Vaccine Centre, London School of Hygiene and Tropical Medicine. So yeah, it's a really worthwhile looking at piece of work.
Absolutely. Yeah.
Cool.
Thank you for being here today to do it with us, Asha.
Yep.
So that was the formal getting to know you bit. We like to also do a little informal getting to know all of our guests when they come on. So today's icebreaker question is, if you could eliminate one food from the world so no one could ever eat it again, what would it be?
The first thing that comes to mind is meat. I'm a vegetarian and I'm like, we don't need to eat meat.
Okay.
And part of the reason I became a vegetarian is a real interest in care for the environment and the amount of growth of plant product that you need to feed an animal to then feed a human is actually about 8 times more than just the plants you would need to eat as a regular vegetarian. So I'm going to go with, let's get rid of the animals that we're killing to eat for meat and let them live and do what they need to do.
Yep.
That's my one, but I may have offended a few people who love their steak, but
That's okay. That's okay.
Yep.
I feel like I'm going to offend people with my answer as well.
Oh, I'm 100% going to offend people with my answer because This is an emotional one for me, and anyone who knows me knows this always comes up. Just get rid of bananas. I cannot stand. Exactly. I can't stand the smell of bananas, the texture, and it all really stemmed from a childhood thing. There was a kid that came over to our house one day and just had some medication and got really sick, and so he vomited all the way to the bathroom. And my job, because I was a kid and that happened to be what I had to do, was clean up the vomit. And he'd clearly eaten banana, and chunder banana is pretty smelly, right?
It's so gross.
So when you have that,
I'm okay. I'm having a visceral reaction to that. Sorry.
And that is why you'll see my lovely team members often would have their banana outside before they come in, and they don't put their banana peel in the bin when I'm about to go there, because it's just everything just gets going for me, and it's just banana.
It's banana.
It was just that one experience.
Not even a banana smoothie.
No,
Especially not a banana smoothie.
Definitely not banana smoothie.
What about banana lollies?
Oh, no. It's the smell
the
then.
association.
It's too close. Yeah. I try not to think about it, but it's the first. It smells, right? It smells and texture.
It's intense.
Yeah. So I'm sure I've offended a lot of people for that, because people love their bananas. What about you?
I have 2 words for you. Tinned tuna. Yeah.
It doesn't even look like tuna, to be fair.
It doesn't look like tuna. It doesn't you don't need to eat it in the staff room when I'm in there. I'm not talking to anyone in particular. I've always had an aversion to tinned tuna, and it's not a very social food.
No, it is not.
I
would
don't like
agree.
it anyway.
Yeah.
The smell of it just sends me over the edge. I can't.
So do you,
I can't be in the room with a can of.
So would you relocate?
I'd have to relocate.
Yeah.
That's like me when bacon's cooking.
Yeah.
Fair. Yeah.
Relocation. Yes. Now everyone knows that. They can. If you see Asha or I in the lunchroom, or Dana,
turn around and walk the other way.
Don't bring your bacon. Don't bring your tinned tuna. Don't bring your bananas.
Yes, and it's good to know these things, because this is how friendships all start. Really, it's usually over food.
Yeah, and how friendships might be ended.
It's true. I feel like I can't find a segue into this topic.
No, I'm sorry.
This is a hard one.
We sometimes
Normally
do try and be clever.
I've got a cool story.
Oh, yeah.
It's not a food-related one at all. But last time I was here, I was talking about COVID, right? And the really interesting thing that connects COVID and RSV is that COVID got rid of RSV. And so for that first year in 2020, we just did not have any RSV in WA. It always comes every year in June. Every year, June, we see the peak of kids with RSV.
Yeah.
And in 2020, it didn't happen. We were watching, we were waiting. We're like, where has RSV gone? Disappeared. But it came back in November. And so all of a sudden in November, when we're sort of starting to wind down a little bit, thinking the children's hospitals are going to be quiet, massive RSV, 2.5 times more cases than we would normally see in a winter season. So crazy busy.
Yeah.
And then the following year it came in summer again. And then gradually we've just been pulling it back. Well, I don't know if we've been pulling it or it's been pulling, but this year it was in September. So we've just really finished the big RSV peak for the year, and it still hasn't made its way back to June. Yeah. So we're sort of wondering when that's going to happen. So that's my segue.
That's
COVID to
segue.
RSV. Didn't involve food at all, but I just thought,
I like it nonetheless.
From families' perspectives, it was really an unusual experience, and for doctors' perspectives, we're so used to winter busyness.
Yes.
And we didn't have it, which was a blessing. But then we were not prepared for that summer experience. And we were the first place in the world to have that happen. So here in Western Australia, it started as well on the East Coast, but because we were so isolated because of the lockdowns and the closed borders, I should say, more than lockdowns in WA, we just didn't have any sort of intersect with other sort of respiratory viruses in the world. And then all of a sudden in November, it just started to take off. And so we did a lot of research at the time trying to describe where the respiratory viruses had gone, why they disappeared. And then when we saw RSV come back, we really wanted to find out if it was affecting kids in different ways. And eventually described, because all the clinicians' hospitals like, it's far worse, it's worse than we've ever seen before. It's like crazy busy and all the kids are going to ICU. In fact, no more kids went to ICU than any other year. In fact, they were having the exact same symptoms, same length of stay. Most of the things were almost identical to the winter experience. It was just that it came at such a different time. We weren't expecting it. And I guess we're just like, whoa, this must be different.
Yeah.
So science is cool when you sort of study something and you discover that it wasn't that different.
Yeah.
But today we're talking about how to prevent it. So now the really exciting stuff on the horizon is that we've got a vaccine and we've got an antibody that can prevent RSV. So potentially in the next 2 years, we may see this disease disappear.
Wow. That's mind-blowing, because what you've described there reflects my personal experiences with RSV. The November after all the first, emergings of COVID in WA was when my eldest daughter got sick with it, and we didn't know what it was, and she was really unwell. We ended up at the Children's Hospital with her, and then I gave birth to my next daughter in the March, and by the November the next year, we were in the hospital with her because she had RSV. So I suppose before we get into any more on RSV, for our listeners, I think we wanted to start with a little bit of a crash course on what it actually is. And we've all danced around it, what RSV actually stands for.
I'm avoiding it.
Which is... I'm going to have a go.
There you go. Thank you.
We'll let the doctor do it.
Yeah, that's right.
The full word is respiratory syncytial virus.
Thank you.
RSV, and then you don't have to say it ever again.
We're not saying it again.
RSV.
Okay.
So tell us, what is RSV?
So because it's got virus at the end, we know it's a virus. It's a virus a bit like, say, flu or COVID. They're all viruses. They affect the respiratory tract. And why this one matters is because babies usually have no immunity to it after the first few months of life, and that their mum's sort of antibodies have disappeared. And it usually causes breathing difficulties for babies. And so in that first 6 months of life particularly, especially if babies are born premature or they're born with another medical problem, they might have an underlying developmental issue, or they may have other medical problems, then they're slightly more at risk of getting sick and needing to be in the hospital. And usually what you'll see is a baby who's coughing, has a fever, and breathing really fast. And sometimes this thing that pediatricians call work of breathing, which is basically where you see them stuck in sort of in that little notch at the bottom of their neck. And I don't even know if the video is going to pick this up, but they're really breathing quite fast, more than 60 breaths per minute, but also you can see the ribs outlined. You can see their tummies really pushing hard to breathe, and they're struggling.
Stressing. Wow.
It is,
For parents, for sure. And also when they get to that sort of stage, as doctors, I like them to be coming into hospital so that we can check them out, or at least go to their GP and get checked out so that there can be some reassuring. So it is a virus. We pass it from one to another by sneezing, coughing, not washing our hands when we touch surfaces and things like that. And it's a virus that really affects children when their airways are smaller and probably a little bit floppier. And as they get bigger, as well as they get exposure to it each year, then they're less likely to get sick. So I know we're just talking, Ash, that your 18-monther was sick in that first summer. That was the thing that was different, which I didn't talk about, was the kids were older. It's because they had all sort of grown through a year when they didn't get RSV. So it was about 18 months from the last time we'd had it in the state. And so there was just a whole cohort of kids who otherwise would have been sick in the winter, were 6 months older than they otherwise would have been, and then got sick. So your story fits perfectly with the absolute epidemiology we saw.
Wow, that's so interesting.
It really is, isn't it? And I have to admit, during, in terms of how it gets spread, and there was so much education around at the time during COVID where, germaphobes like me are kind of like, yes, everyone can wash their hands, no shared things. And then over time, I have seen that almost come back to what it was pre-pandemic levels, which I'm very disappointed about. Do you think that has a lot to do with what we're seeing? What kind of role in terms of that prevention level in what we saw? Was that we didn't see much of it because we're a bit more careful with our hygiene? Or
Absolutely. It disappeared, completely disappeared, because we were not connecting with one another. So we're obviously in those first few months that were really, really quite scary in COVID. We were staying home, schools were closed, people weren't, the pubs were closed, the restaurants were closed. I think practically everything was closed. We even had set hours when we could go to the supermarket. We just weren't mixing with one another. But we were also washing our hands more. We were I think it was probably those two factors that led to RSV not taking off in that winter period.
Yeah.
And because that same behaviour was happening globally, it disappeared everywhere. So it's absolute proof that washing your hands, staying home when you're sick, staying away from other people is very effective.
Yeah.
And I think there are two things we can still do. We can wash our hands.
That's right.
Everyone's got alcohol or an alcohol-based hand rub, not necessarily alcohol to drink, or a sink where you can wash your hands. Yeah. And you can always respect your friends and family by staying home when you're sick, even if you want to be out somewhere. If you've got a cough or a cold, it's much better if you keep it to yourself.
Yeah. Virus is a virus, right?
So you can prevent it, which is clear, and that's how we saw that RSV season just disappear.
Wow.
And it does mean that we have strategies that we can use. We have to obviously be mindful that the social disconnectedness of that period of time had huge other impacts.
That's right.
So
of course. You have to balance it out.
I don't expect that we should be doing that all the time.
No.
And I think it was really hard for children and young people to grapple with a global pandemic, schools closing, what could happen if my loved ones get sick, they might die, seeing that happen. There was a lot of mental health burden from that. So we always have to be balancing, what is the worst thing that could happen here?
Yeah.
And RSV as a respiratory virus has a big impact on very small babies and also on the elderly. So that's one we want to prevent. And now we've got more than just washing our hands and staying home. We've got some strategies.
Yeah. That's really good.
That's great. And sorry, Dana, you go. I was just going to ask about the testing for RSV and how you actually know if a child has RSV or if it's some other virus. I remember being in hospital and doing the PCR test, which was it's always fun with young kids. But I was not, I don't know if surprised is the right word, but, the process is quite similar to like a COVID test or something like that, isn't it? Yeah.
It's pretty much the same thing. And one of the advances that we have got to, I must say, is that when I first started as an infectious diseases specialist, we always did this thing called a nasopharyngeal aspirate, which is basically putting a sucker into the child's nose and sucking out the snot way down deep. And that's the sample that got sent off to the lab. So, in fact, we've come a long way from there.
Yeah.
And now we use what's called a flocked swab, which in my mind is a bit like a dust mop. You know those dust brushes that you like have around the house?
Yeah.
It's got lots and lots and lots of surface area, and so it can pick up the cells of the virus in the nose. And that sample, it's a tickle, but it's a lot less discomforting for babies and for everyone than
suction.
The suction.
Oh gosh, yeah.
And
my nose is itchy just thinking about it.
So that flock swab gets sent to the lab for a PCR test, and so we have actually expanded over the point of COVID to having tests available now that run all of it at the same time.
Yes, I saw these on, I can't remember where I saw it, if it was on some kind of social media, but it was the rapid antigen test that had the 3 lines. Is that right?
So you can do a COVID test and both flu tests. You can buy those at Coles and get those 3 tests done at the same time.
Wow.
I haven't seen too many that have RSV testing for home use. But when you come to the hospital, you go to your GP and they do a COVID test, the same test platform would also look for RSV and influenza. And then there's a whole bunch of other respiratory viruses like parainfluenza virus, which causes croup. You know, that barking cough that children get? There's something called human metapneumovirus, HMPV. We shorten everything. And
good reason.
HMPV behaves a lot like RSV.
Okay.
But it's a different virus, and we don't yet have prevention strategies for it. And then there's all the non-COVID coronaviruses, and then there's the bacteria that make you sick as well.
Oh, my goodness.
Right now, they're all on the same test platform. And so usually if someone comes into the hospital, we can get an answer within an hour or 2 of which respiratory virus is making them sick. And often the kids who need to come into hospital have 2 or 3 at the same time.
Wow.
Yeah.
Which is also pretty crazy.
Wow. Yeah. Well, it's quite intriguing because I know the last time we spoke, we were obviously really worried about COVID, the impact it had on kids, which we were like, didn't seem to have as much of an impact. But RSV obviously really does. Why is that the case? Why is RSV such a dangerous virus for so many of our young kids?
Yeah, it's a super great question, Dana. And I don't know that we have an absolute answer to that one. I think the smaller airways, as well as the lack of immunity and not having a vaccine for it, are probably 3 contributors that make it a really big problem for babies. And the respiratory virus, I think eventually we're probably exposed to it every year. And so we just develop that immunity from recurrent exposures so that those babies in that first year, no immunity to it and get very, very sick. So it was baffling to everyone as to why kids didn't get sick with COVID because they didn't have immunity. They'd never seen it before. I think ultimately the science that we have discovered is that there were probably receptor differences. And so children had fewer of the receptors that were needed to really attach the COVID virus and then make people sick. That was really way back right at the start of 2020 with the ancestral virus. But as it mutated, we developed the different variants of concern. We're now in Omicron. And it became less of those features. So kids were more able to get infected than they had been early on. So we've done some global studies looking at that to try and understand whether that impact affected whether they're hospitalised or not. So we actually found across the course of COVID they were more likely to get into hospital, but had better outcomes. So that was sort of good news across the world. And why that was the case with COVID and it didn't really infect kids nearly as much early on was good news. But it also really confused public policy. Because public policy was very much focused on RSV and flu. And those 2 viruses always affect kids. Kids are considered snot vectors. They're like, you don't go to a 4-year-old party unless you want to get sick.
Yeah, that's right.
But COVID didn't behave that way. And so it really did confuse policy makers for a really long time. And they just kept going, no, it's just like flu. And as pediatricians, we were pretty much shouting from the rooftops, it's not like flu. It's not affecting kids in the same way. Please stop closing the schools. This closure of schools had a huge impact on children and their well-being. And so it's just interesting. The 3 respiratory viruses, they're affecting kids in really different ways. And you have to learn about them and study the epidemiology so then you can make your public policy and not just have fixed opinions. That's a bit of the end of my rant on that one.
Love it.
But I spent most of COVID going, please stop closing those schools.
So Asha, I'm really interested to know if there are any, I suppose, long-term consequences of RSV. We talked about COVID a bit, and I suppose if we're drawing parallels between the 2, even though they are quite different, we talk about long COVID, and that's something that people have in their minds when people come down with COVID. But can the same be said for RSV? Are there any long-term consequences that we know of?
I think this is something that we found really interesting when people started to talk about long COVID. We're like, actually, we have no idea what other respiratory viruses do longer term.
Wow.
But the vast majority of children who I would look after in the hospital and then see for follow-up get sick, they get better. Usually for RSV, it's sort of about a 5-day illness in the babies, and on day 3 is the worst. So day 1, day 2, they're coughing, they're snotty, it's hard work. But day 3, they really start to labour with their breathing, and that's when they often come into hospital for day 3, 4, 5, and then go home after that. And the vast majority of babies will get better and no problems from it. Some children will have, that could be a trigger for asthma developing. And so that's the association that is the most common. And whether it was the RSV or whether they were prone to asthma already has not really been fully teased out, but it's common enough that it's probably quite likely. Some children will get pneumonia after having had RSV, so they might be sick with that respiratory viral illness and then come back in a week or 2 later, not necessarily to hospital, but maybe to their GP and have a bacterial infection. We always see every year, this is another fun fact from infectious diseases world.
I love it.
You get a peak for influenza, and then on the tail of influenza, we get a lot of bacterial infections, pneumonias, bloodstream infections. And then usually influenza comes in August and RSV comes in June. But this year it was the other way around. So influenza came first in June. So we just got over the sort of bacterial infections and then RSV took off. And in the peak of RSV, you don't see too many bacterial infections. And so it's reasonably quiet, I guess, from the bacteria side of thing. And then as you just pass the peak, all of the kids with bacterial infections start to come in. And pneumococcus causing pneumonia, ear infections, even meningitis, really quite common in the back of RSV. But we also saw lots and lots of invasive group A strep this year, lots of staph bacteremia. So you start to see those longer-term consequences making kids really sick, and it happens every year.
Yeah.
So as an infection specialist, I'm kind of like at the peak of RSV. Oh my gosh, the busy times are coming.
Yeah, you're thinking about the next which is the bacterial side of things.
Yeah.
So interesting.
So does that influence then, like in terms of treatments, and you often have people who would go to the doctor and go, hey, can we just have antibiotics? And you're like, no, it's RSV,
it's a virus,
right?
Yeah.
You would obviously want to keep that in mind in terms of the phases, knowing when things are happening to go, like, now's the time. Like that must come into play, I gather.
Yeah. So I think clinically decision making, if a child's just had a respiratory virus and then they're coming back with new temperatures, that would be the time where you go, oh, this really does need to be worked up properly and antibiotics given. Sometimes, most of the time, to be honest, kids will be safe with oral antibiotics at home prescribed by their GP.
Right.
It's when they're, I guess, not keeping those down, their temperatures won't go away, parents are worried, they need to see a paediatrician. So bring them into the hospital.
Yeah. Really interesting.
I think this all leads really nicely, like this background and this picture that we're painting about RSV and actually how complex it can be when you start to think about all of those, longer term or secondary consequences to a virus. Leads us beautifully to this study, which is looking at the other side of the prevention side of things. And we're talking about the development of a vaccine that can actually target RSV. So can you tell us a little bit about the trial that was part of this study and how that fits in our kind of phases of research as we think about them?
So there's been lots of work being done for many years trying to find a molecule that would be effective as a vaccine for RSV. So that's been quite an elusive scientific goal.
Yeah.
And then they discovered, and this is why this particular paper is called the Bivalent Prefusion F vaccine.
Yes.
Because they discovered that it's actually before the RSV folds on itself that you can develop an antigen target which will produce antibodies. Afterwards, you can't. So that's been quite a big scientific discovery that's been really important for this virus, and so has led to the ability to make vaccines. I hope I've explained that sufficiently, because the scientists involved, like, man, that is cool science.
That is like pretty
not something that I do, but it's pretty awesome to know that that discovery has really led to the ability to create a vaccine. So this particular paper was looking at immunising pregnant women. And we know that mums, when they're pregnant, generate antibodies, and those antibodies cross the placenta. And they mostly cross the placenta after 28 weeks or in that third trimester. Before that, not too many antibodies cross. So babies born before 28 weeks really don't have that level of protective immunity from their mums. But afterwards, they start to cross the placenta in preparation for birth, because in those first few months, their babies are most vulnerable. So it's a pretty cool design, I think, to know that that's what's going on in pregnancy to protect babies from these viruses.
Yeah.
And so we know that it's safe to vaccinate women for the whooping cough vaccine during pregnancy. We know it's safe to vaccinate them for influenza, both for their own benefit, because women who are pregnant get quite sick with flu, and you can save lives that way, but you can also protect the baby. So those two vaccines have now become quite routine. And so this particular study, they were looking at, can we vaccinate women in pregnancy and then use the outcomes in the babies as sort of the end point of the study. So the goal was always to protect the babies. It wasn't to protect the mums. And there was, I think, almost 4,000 women in both sides of the study. So it was an enormous study. And so this is the kind of study that we call phase 3. I think you asked that question. So phase 1 would be when we're starting to look at a particular molecule. Is it safe in humans? So we would usually test it on men. And usually they would be adult men. The reason for that is because the that's how clinical trials have been done for a long time.
Wow.
As a female, we're all females here. Sorry, Eddie. It doesn't really feel fair that that's the case.
Yeah.
But I think it's because of the concern that, what if a woman's pregnant and this might have an impact on a baby. So that's kind of historically where it came from. But any adult, you could test this particular looking for safety and then start to figure out what the right dose is. And so usually sort of that's going from phase 1 into phase 2 where you're starting to go, oh, it's safe. That's good. You're just trying to work out what are the dose range limits for this. Like how much of it is too much? It might cause harm. How much of it is not enough and it doesn't do anything? And so that's sort of trying to figure out what that dosing level should be. Once those questions are answered, you're pretty much ready to go into a phase 3 trial. So you've got as much information as you possibly can and you're going to progress it. And so there are a few trials done with these vaccines. One was in the elderly to try and protect them from RSV. But this particular one in pregnant women is so novel because it was, I guess, vaccines. Everyone thinks will limit everything that we possibly do for pregnant women. We don't want to cause any harm. We don't want to risk anything going wrong. And so for those reasons, it was a big deal to recruit these ladies. And I think it was done in 18 different countries. And so it was a real global collaboration. And people coming together and saying, we'll be a trial site. We'll be a trial site. We'll get involved in this. And one of those sites was here in Perth. We're led by Professor Peter Richmond.
Really?
So there were some kids in Australia who were in this particular study.
Wow.
It's amazing.
So that's the way that evidence gets generated. But all of these women in the study, and then their babies were followed up out to 6 months and tried to work out whether they had any medically attended RSV illnesses. So you could have had RSV potentially and you didn't go see a doctor. You didn't get counted. But if you went to see a doctor or you ended up in hospital, that was what was counted as sort of the result of the study. Does this vaccine in pregnancy protect? And the great news, it does. Oh, my goodness. Wow. Super exciting.
So exciting.
And I love that you've just gone through that whole, the generation of that science and that knowledge because it's confidence in the results, right? To have such a big population across so many countries, to be at that phase 3. This is one of those things I guess distinguishes between like real science and those results that can be applicable. And because obviously with vaccines over the past few years, there's been a lot of discussion, there's been a lot of that, and it's all really come down to, I guess, sometimes confidence in the science and, being able to test it amply. But the way you described it there, I just go, that's incredible. Isn't it?
And so I suppose like putting your clinician hat on and taking your research hat off, if you weren't involved in this study and you looked at the paper and saw these results, why is that of importance to you as a clinician, I suppose?
Well, I've talked a lot about the wave of RSV and all the babies coming. And as a pediatrician, it's heartbreaking still to watch a baby suffer. And when they're really struggling to breathe, then you want to offer everything you can, but we don't have a treatment for RSV. So all we can do is support them. And so that often means things like a nasogastric tube so that they don't have to feed as well as breathe. But, that's not necessarily an easy procedure for a baby to have, but it's something we need to do. We try very hard to avoid putting cannulas into babies when they've got RSV because sometimes that can cause them to hold their breath and then get more sick. So there's things that we have tools in our toolkit to care for these babies, but if we could stop them from coming into the hospital, oh my goodness, game changer. And I saw this as I was just early in my infectious diseases career, just starting to train, and the rotavirus vaccines came in. And those ones were studied on about 70,000 children globally before they got approval because there were some real concerns about a safety risk, which was something called intersusception, where the bowel tunnels on itself. So because of that background concern, they had to have lots and lots and lots of kids in these trials before we said, yep, this is a vaccine we're going to accept. In 2006, I was working in the ED, and that was the year before the vaccine came in. We used to have wards of kids with rotavirus. It has a particular smell. It's got a particular pattern. It was well recognised. And once the vaccine came in 2007, we really saw across Australia no more children for vast majority in Darwin and Alice Springs. We're still seeing kids for a couple more years, but beyond that, we saw it disappear. So rotavirus is now part of our routine vaccine schedule.
Yeah.
Every single baby gets it as a vaccine. Yeah. It's an oral drop on their tongue. And so I don't have to resuscitate children. Like they used to come in, they needed to go to the ICU really, really critically unwell from dehydration. Yeah. And it was one of the biggest killers of children. And so we don't see that nearly as much. Yeah. RSV contributes to pneumonia, which is the number one killer of children globally. Yeah. So if we could get a vaccine in pregnancy to not just save kids from coming to hospital here in Perth, but save lives globally, awesome. Yeah. And this one works. Like the study shows that it's 84% effective.
Wow.
So it's like incredible. I always want to, like, we all want gold stars. We all want 100%, right? Yeah. But to get to something like an 84% vaccine efficacy is probably one of the best vaccines that we've got out there.
Wow. That's
and so there's lots and lots of babies in the future that won't need to come into hospital. Yeah. And potentially in developing countries won't die of this disease.
That's phenomenal.
Which is incredible.
Yeah. I was just thinking about that as you were talking, you know, the impact that it has on the healthcare services to have a vaccine like this rolled out and to not have these babies presenting to hospital, you know, because the burden of that at these times where there are peaks of these illnesses, it must be just incredible.
Yeah. Well, I think the thing we're hopeful for is that the emergency departments won't be quite as busy. Yeah. And because for families who really need emergency department, and all of these babies need to come into the hospital, but when they're all there at once, it's
and you
pretty
see them
stressful.
All. Like you're sitting there with your baby and you can hear them and you look over and you see 3 or 4 other babies and you think, okay, we're all here for the same thing.
Yeah. It's really stressful for families. And so if we can see this disappear, that would be amazing. Yeah. I can also, like, this is one of my random stories, but I was, when I was a first-year researcher, first-year Ph.D, I was setting up a clinical trial in remote communities in Northern Territory. Mm-hmm. And one of the places that we were hoping to recruit some children, I went to the clinic in the morning and I was like just introducing myself, letting them know what we're doing. And I said, I'm a pediatrician. I'm here. Like I can see any kids you need me to see if you have a pediatric concern. Yeah. But I'm also here. We're trying to like set up the way to recruit for this particular skin sort study. Mm. And so that's what I'm probably most famous for is all the work I do in skin infections. Yeah. But this baby came in that night. And I just kind of popped back into the clinic to say, I'm on my way out. And they're like, we need you. And this little bub, 3 months old, had RSV. Oh, gosh. And was really struggling to breathe. And I actually had to put a breathing tube in to help this baby. And we had a team come and take the baby back into Darwin for support. But I was avoiding it because if you don't need that, you don't want to do it. And if, as a pediatrician on my own, if I didn't need to intubate, I would prefer not to. But we got to the point where I was like, this baby's critically unwell. Yeah. I've got the skills. Let's go for it. Yep. Praying the whole time that the baby would be okay. And she was. And I saw her about a month later come back to community and was looking fantastic. So it was a life saved. And a vaccine like this would be preventing that sort of drama happening in that sort of very remote clinical space as well. So
significant.
It's across so many different specters.
Yeah, absolutely. So this study... you talked about the 18, I think it was 18 different countries, is that right, that had sites that were involved in this study. Mm-hmm. But I suppose when we talk about the rollout of these results, how does that happen? I'm thinking about here in Australia, but I imagine every country has a different process and a way that they then go about implementing this evidence. Yeah.
So we're at that point now. So the vaccine trials have been done. Mm-hmm. And there's actually, we haven't even talked about it, but there's also an antibody that's been developed that will work to protect from RSV. So these two pieces of science have happened simultaneously.
Oh, gosh. Okay.
And so for the antibody, it's been approved by the FDA and the EMA, so in the US and Europe. And I expect that will come into use probably this winter.
Wow. Okay.
In Northern Hemisphere. So we're going to be really watching the space to see what happens next.
Amazing.
And that hasn't yet been approved in Australia, but I think it will come through pretty soon. But this vaccine as well is going through that regulatory process globally. And once it's gotten through all of those processes, it does get listed onto a vaccine schedule. It depends on exactly some of the health economics, like how much does the vaccine cost versus the prevention. And the government has committees that make those decisions. But then ultimately, and I think families will probably be familiar with this from COVID, we have this committee called ATAGI, which is the Australian Technical Advisory Group on Immunisation. And we saw them over and over and over.
We became very familiar with ATAGI.
ATAGI's got a new decision. So they will be tasked with working out how to best use these vaccines and also the prevention antibody. And each country is coming to slightly different conclusions on that. So I think we'll eventually have, in my mind as a scientist, I like these kind of opportunities. It's almost like a natural experiment where different countries have decided to use these therapeutic options differently. So we'll be able to really compare which one works better, what might be the best approach. So for Australian families, we're not there yet. We don't have these ready to roll out. I'm hopeful we'll have some good news pretty soon. Maybe sort of towards the early part of next year. We might find out whether these are going to be offered to children in Australia. And particularly that antibody one, I think is going to be a really important next step. But the efficacy of the vaccine is so good that it's also going to be part of the strategy. And so far, we don't actually know how to use the two together either, because they haven't been put into a clinical trial at the same time. And theoretically, the vaccine would be developing the same sort of antibodies that you're giving a baby with the antibody injection. So strategically, everyone's still trying to go, how are we going to use these? What are we going to do? So from a family's perspective, I think the good news is there's hope really exciting on the horizon. And the scientists are working their way feverishly trying to figure it out to figure out what the best strategy for Australia will be.
I have so many questions about this.
I know.
One of the questions I have
I can see you like
is around what you talked about with the vaccine schedule and how you kind of implement something like this into a vaccine schedule, bearing in mind all the kind of quirks that you talked about with the peaks of RSV and how maybe they're not now what we're used to seeing typically. How do you manage all of that?
Great question. We are expecting RSV to keep on bringing itself back to June. So I think it'll be there eventually soon. It's definitely a winter virus again now, so that's been helpful. But the question I think is really important. So if you vaccinate a woman in pregnancy, if someone gives birth sort of right at the end of winter or early spring, their baby actually will have the antibodies during summer, which they wouldn't typically be exposed to RSV. And so by the time they get to winter, they're going to need something else to protect them. So do we offer the vaccine in every single pregnancy, in every single month of the year, just in case there's some benefit? Or do we tailor the vaccine strategy to when it's going to be most protective? What phase in pregnancy do we give it? Mostly we tend to wait for that third trimester, partly because of the antibody process, but also because all of the developmental phases that could be harmed by something being given have already been passed through. So we try to avoid the first trimester when there's a whole lot of exciting development happening. And mostly in that last trimester, babies are growing big. They're putting on a whole kilogram during that 3 months. Like, it's crazy.
Sometimes more.
Yes. They're growing so big. But so trying to match when the benefit will be is going to be part of that strategy. And also I think the cost factors will also come into that. Like, do we routinely give every pregnant woman in the third trimester influenza, whooping cough, and the RSV vaccine, or do we partner RSV and influenza sort of in the way that influenza usually only comes out in winter and it's only here for sort of a 3 to 6 month window? Do we put those two vaccines together? I don't know the answers to those questions, but those are the ones being debated at the moment.
Things to consider.
There is.
So, I mean, what's really exciting about all of this, I guess, to sort of wrap up, we've spoken about so much, but you've got the vaccine potentially to prevent. So for the children who are already born, they're 1 or 2 years of age and still at risk of getting RSV, that's where the preventative antibody will come into play. So like everyone here is going to benefit potentially. Yeah.
So
God, that's huge. Yeah.
It looks like the preventative antibody will be given to infants in the first year of life, and then high-risk infants in the second year of life will probably receive it as well. Yeah. And that's because I guess babies who've got other medical conditions, often heart or lung problems, will be better protected if they have it for the second year of life. But we'll see. Will that push RSV back? Like, will kids then get sick later in life, or will they be older, their lungs are more mature, their airways are bigger, and so they don't get so sick?
More questions to be answered.
We'll have to keep doing epidemiology as well as science, as in like discovery science, and then the cycle will just continue.
It's the excitement of science, though. It keeps building.
It does. I think I could maybe go back and become an epidemiologist.
I think you'd be great. You ask good questions.
No, well, no, I find it so interesting. Maybe I'll retrain.
With what time, my dear? No, but I think it's a really exciting, interesting space. And we're just so grateful that you came in to talk to us about this today, because I think for me, just to read the article, like I get the gist of it, it's incredible. But to get that background from a clinician's perspective is just so invaluable, isn't it? Like,
you know, we talked at the start, Asha, about, you know, all of the incredible work that you do. And I think the fact that you do wear your research and your clinical hat is just, such a powerful combination of skills.
Thank you. It's been fun being here again. I do love it. So if you want to hear about any other respiratory or bacterial infections.
Look, I think she's our infectious disease expert. Every time something comes up, we talk to you. Okay. You're going to keep coming back, so we'll keep
friend of the show.
You. That's right.
Yeah, love
it. It's a good title. It's a really good title. So to all of our listeners out there, if you want to have access to our run sheet notes, what we spoke about today, as well as the article we spoke about, please head to our website, researchworks.net. And remember, there's a CPD form that you can fill out as well to keep this as part of a record of your PD requirements. I think I said that right.
I usually do.
Yeah, it's usually my usual spiel.
Yeah. CPD, RSV, so many acronyms. I think it's time for us to go.
That's right. I walked, quick while we're here, just in case. But thank you so much for coming. I know you've got such a busy schedule, so really grateful. And it's really funny because I think we tried to do this a little bit earlier, thinking it was the peak of RSV was happening, but everything got pushed back anyway. So we're right there.
Turns out fell into line beautifully.
We did.
We're good.
We did. Yeah, we're really good. Yeah, so thank you very much, and we'll talk to you all again next time.
Thanks,
Bye.
Asha. Bye.